Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. Today's episode features content from an educational program titled Contemporary Management of HIV 2021. During this podcast, Dr. Geeta Gupta, Professor, University of California, Irvine, and Director, AIDS Education and Training Center, discusses ART management in heavily treatment-experienced patients. For more information about Dr. Gupta and for a link to the full online educational program, including downloadable slides specific to today's podcast, please visit the link in the show notes for today's episode. Now, let's get started and hear what Dr. Gupta has to say about ART management in heavily treatment-experienced patients.
So first, how do we define heavily treatment-experienced patients? And what we're usually talking about are patients who have virus with resistance to multiple classes and have either no or very limited treatment options. Usually we're talking about, here it's divided into two target populations, but I actually look at both these populations as one. And it's people who began ART with less potent regimens that had low resistance barriers and have been on many regimens. So they have been on therapy for a long time. So it's divided here into two sections: older people with less potent, that are now even older, but they've probably been on antiviral therapies for 15 to 25 years. And then the younger people that we find with this situation are those who were born with HIV. Congenital or mother-to-child transmission is how we term this. And as we'll talk about in the talk, new drugs in new classes with new mechanisms of action really are essential in treating these types of patients. So just remembering what the timeline of drug availability was. First, we had monotherapies with NRTIs. Then we had in the mid-90s, or when the PIs and NRTIs came up, but they were still difficult regimens. And so the issue of heavily resistant virus has been throughout until I would say the mid to late 2000s. That's when we started getting more drugs with higher barriers to resistance. And up till that time, we really had to deal with this case in a lot of our patients. And in fact, if you see, this is a percentage of highly resistant virus that was detected on people who were getting resistance testing in the United States. You can see that it went up to as much as 7.5%, and now has gone down to less than 1%. And I think that certainly jives with my clinical practice, and I'm sure yours also. So this first case is a 56-year-old man who's diagnosed with HIV in 1992. Had a baseline CD4 count of 150 cells. Otherwise, not much in the way of past medical history except for some dyslipidemia. So he became diagnosed positive at a time when we only had NRTIs. So now you look at that second bullet, the treatment history, a panoply of drugs, first monotherapy with NRTIs, then dual therapy, then we went to triple therapy, first using protease inhibitors, also using NNRTIs, and used multiple ones. And he was persistently detectable throughout this time. Now we jump to 2007 when we had the new availability of a very potent regimen. Darunavir had come on the market, raltegravir had come on the market, and then etravirine came on the market. So he ended up on that regimen along with enfuvirtide, what we know as T20, the injectable drug. And so he started on it. He had some intermittent suppression, but poor adherence due to injection site reactions with T20. Now, jumping forward to 2015, we see that he's on boosted darunavir, raltegravir, and etravirine still, and that T20 was replaced with NRTIs. And he was viremic at this time, and a genotype showed pan-resistance to NRTIs and NRTIs and PIs. And as he had been on raltegravir, he also had resistant mutation to integrase inhibitors, but he did have R5 tropism. So his profile test showed the R5 tropism. So that is why Maraviroc was added to his regimen. The boosted darunavir was kept, made it BID, which is what we use in patients with resistance. FTC TAF was remained, and dolutegravir also put at BID due to baseline INSTI mutations. So this worked. He was suppressed. But you jump another 5 years, and although his CD4 count is great, 824, he has a persistent low-level viremia from 1,000 to 2,000. And we order resistance tests. So how do you manage such a patient? How do you evaluate such a patient? Why do they keep these very good regimens, very potent regimens? And the very first thing we got to think about is adherence, and we have to assess their adherence. 95% of the time, the reason for failure is because of poor adherence. But drug interactions, drug-food interactions can also lower drug levels. Drug tolerability, if patients just can't take it, if they vomit their drugs. We want to see what the HIV-RNA, the viral load, and CD4 count is doing over time. And what is critical is getting current and past resistance test results so we can formulate a new regimen. Showing how important adherence is, this trial, very interesting, it's just an 8-day trial that I believe was done by the NIH for patients who were failing their regimen, and they admitted them to the hospital and basically gave them directly observed therapy, DOT. They didn't change their regimen at all. What happened? Of the 29 of them, about 50% of them had a virologic response. So what's the difference between responding and not responding? One is if you haven't been taking your medication, if adherence is poor. Now, there was age that was different between the responders and non-responders, et cetera. But I think that the major thing that would distinguish the responders from the non-responders are here in this red rectangle. When you look at the number of major and minor drug-resistant mutations, DRMs, among the responders, there were 5 mutations, non-responders, 18. They had a lot more resistance. And then the median GSS, that's the genotypic sensitivity score, that measures how many drugs by the genotypic assay, how many drugs is the virus sensitive to in that particular patient. And in the responders, they had 2 drugs that were fully active. But in the non-responders, you can see only 0.1. That's the median. So there are several reasons why those patients did better. Now, did they maintain it? They were given DOT for 8 days while they were in the hospital. Of the 6 that ever got to a viral load that was undetectable, only 1 maintained it at 6 months. And I believe that is going to be due to most likely adherence. So when you select a new regimen, these are the DHHS guidelines, we want to perform the drug resistance testing, preferably while the patient is taking the failing regimen, because that failing regimen results in a drug pressure, which may bring up in higher population virus with mutations that are resistant to that failing regimen. If for some reason a patient comes to you who has stopped that regimen and is no longer on medication, you still want to get a resistance assay, although it may not have the same results as in this case. And we want a new regimen that should include 2 and preferably 3 fully active agents. And again, a fully active agent means that there is no predicted resistance based on the resistance test. We know that drugs with a novel mechanism of action that the patient's never seen before will be an active drug because the virus has not had that selection pressure. Adding a single antiviral therapy to a failing regimen is not recommended. We've tried that, done that, and it generally fails. So the drug resistance testing and determining what resistance the patient may have, we do in two ways. First of all, we want to know their antiviral therapy history. Secondly, we want to get resistance assay results. This would include current ones as well as previous ones because we think that drug resistance is cumulative. The mutations that have occurred in the past, even if not detected now, are archived. They don't disappear. They don't go away. Archived drug resistance mutations may not be detected by standard resistance tests. And so that's why it's nice to get all the previous resistance tests also so that you might be able to pick those up. And if you have low-level viremia, don't discontinue therapy thinking that, if you bring up the amount of virus, then we'll get a better result and be able to do that resistance test. That's trying to time something that we just can't time. It's like trying to time the stock market. You don't do that. There's definitely bad outcomes that can occur from that, including we see the CD4 count decreasing very rapidly and clinical progression. We don't want that. So what kind of drug resistance assay do we order? So we've got genotypic testing, phenotypic testing, and then the archived DNA testing. Basically, we always do a genotypic test. And in first and second line therapy, that's the only test that we generally need. If a person has failure to a first line regimen, generally you only have a couple of mutations. They're easy to understand and interpret, and we don't need the time and expense of a phenotypic test. However, if you've got a patient who has a long drug history, multiple failures, we expect that there may be more in the way of mutations. And sometimes these mutations can have intermutational interactions so that you may have synergy or actually decreased resistance at sometimes. So then we would also want to add a phenotypic test to the genotype. And lastly, in patients who have a low viral load, we can't do the genotype or a phenotype. You need at least 500 copies per mil to 1,000 copies per mil to get a genotypic assay run or phenotypic assay. Then we could go to the DNA, proviral DNA genotypic assay. That assay we'll talk about a little more later, but is generally less sensitive. And we do it again when the other assays are not available to us because of low viral load.
Great. Thank you very much to Dr. Gupta, and thanks to our listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV 2021, on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.